Assessment issues in cognitive behavioral therapy. This is Chapter 4 of CBT in Action, a Practitioner's Toolkit. The following are a summary that I made. So there are stark differences between the behavioral model and medical model according to De Giuseppe 1991. The medical model requires the following: a detailed assessment that leads to diagnosis, and it requires an intake interview where social and psychiatric history is explored. It also involves a lot of people like a psychologist, mental health nurse, psychiatrist, and social worker. As a result, there may be only limited attention to the current problems and limited number of therapy sessions. This process requires the use of inductive reasoning and assumes that the client will reveal personal information early in therapy, which is not always the case. Also, inductive reasoning is starting from the detailed level and then working your way to generalizations to the theoretical component or to the hypothesis. The behaviorist model focuses on the current problem relevant to the client according to De Giuseppe. Trust builds up when therapy progresses and other problems become raised and need to be addressed. It depends heavily on hypothetical-deductive approach, where the hypothesis is formed by the therapist based on underlying cognitive behavioral therapy and cognitive psychology. So in this regard, it's using the generalization and theory in order to make specific predictions, hypotheses. It requires careful attention and collaboration to take into account complex factors contributing to the client's emotional and behavioral presentation. Ultimately, therapists are seen to be working with the clients to create behavioral goals to treat specific problems that the client may have. A diagnosis may be used for medical legal purposes, but is not always needed, especially since many common emotional and behavioral problems can be ascertained without a diagnosis. Avoidance due to anxiety or withdrawal due to depression, for example. Other times, a diagnosis could be used to differentiate between different types of psychological illnesses, which can suggest better treatment, such as, for example, bipolar and PTSD. Many CBT therapists consider that diagnoses are not helpful in making treatment decisions, according to Perron's 1989. Others believe that diagnoses can be seen as a lens that focuses on case formulation, which helps notify the practitioners to specific unhelpful cognitions present, according to Scott and Semby, 2006. Let me take you through an example of an assessment. For instance, an initial assessment is when seeking information early in therapy, and the following is what Lazarus in 1981 coined the basic ID. So B stands for behavior. This can pertain to excessive behavior that needs to be reduced or deficits in behavior. Characteristics of behavior such as frequency, context, and subsequent reinforcers can be explored. The A stands for affect, overall emotional tone that the client is experiencing or the patient is experiencing. S stands for sensations, which is what clients are physically experiencing. I stands for images, which are the cognitions that can be conveyed in pictorial form, thus not necessarily all verbal information. For example, clients can catastrophize and see the worst thing happen or relive experiences through flashbacks. C stands for cognitions, which are unhelpful beliefs, inferences, demands, rules, assumptions, and negative evaluations. Initially, these may not be assessed in much detail. I stands for interpersonal, or how clients react to others and their relationship patterns. D stands for drug, or biology. This is information about prescribed or illicit drugs and how these influence eating, sleeping, and fitness patterns. It may lead to excess or deficit behaviors. It is helpful to see how all these are related in the CBT model, and whether they are congruent or incongruent. We have to realize, however, that there may not be sufficient trust in this early stage to inquire about clients' detailed history of past abuse or trauma. It is also helpful to inquire about the expectations for therapy, according to Beck. It is important to develop a conceptualization of the issues that need to be defined and the goals that need to be set moving forward. Subsequent sessions reconceptualize and redefine the goals. So yeah, this is my summary about the issues with assessing clients. There are advantages and disadvantages to both models used, and that it is important for psychologists to be able to try and use the best of these models in order to help diagnose and eventually assess and treat the client's symptoms and severity. Please let me know if you have any questions. Thank you very much and have a good day. Bye-bye.